Welcome, guys, to Clinical Unfiltered. Give me your hearts, your minds, and your teeth. And today, again, it's just me, Dr. Sausha, but we're going down the implant surgical guide rabbit hole by going through case studies today. So I'm going to go through a couple anterior cases that I did a little bit earlier on in my career, and just kind of show you the thought process and some nuances in the cases. To help you better understand using implant guides and managing just some of these cases. So again, I'll try to like visually talk it out. So in case you're just listening, you can at least get something out of it. And so for this first case, I'm going to share my screen. It's an anterior case. And I always harp on people that if you got a damaged socket, now, we did have an episode about bone grafting with Dr. Wong, David Wong, and both of us agreed that if your socket's beat up in some substantial format, and most sockets are, I mean, you're taking out a tooth because of a reason, you can't just shove bone into that hole and call it a day. Your bone graft is not going to heal that well. Maybe it'll kind of heal, but it'll get granulated. You lose dimension. But often there's a chance for things not to heal well if you've got a really beat up socket. That means socket walls are missing, giant infection, all coming together to make it not like a nice cup to fill bone graft in. And when that happens and you just shove bone in there, problems occur. And I harp on that. But I'm very guilty of it. I am extremely guilty of it. I am a human being working in a practice that time, efficiency, all these things matter. And my empathy sometimes is way too high, especially for this case. So girl walks in, she went to an endodontist and they were like, no, this tooth is done. You're having to lose this tooth. Cracked, fractured, necrotic, failing endo. What happened is she had a scooter accident, and that started to flare up the tooth, and one of those electric scooter accidents. And so when I come into the room to meet this patient, she is bawling. I present on this case a lot. I mean, I was just trying to get people to visually understand. She was crying so hard her shoulders are bouncing. And we have one of those rear entry rooms, so I'm walking in from behind and just noticing her shoulders just bouncing up and down. And so I start approaching her. I'm like, yeah, this is going to be a fun consult. I turn around, and I'm like, I try to draw her in, calm her down, whatever I can try to do to calm her down. Doesn't really work that well. I have to talk through a crying person for this whole consult. And she just knows she's scared about losing her front tooth. Really. And I mean, I take a cone beam and I'm like, okay, maybe I can do immediate implant dentistry, but to do immediate implants, I love doing immediate implants in the anterior. I really try to do immediate implants all the freaking time. It's the best way to maintain aesthetics, get patients to have their teeth right away so they're not sweating that. But there's there are criteria you need to check to make sure it's a good case for it. Not every case is a good immediate implant case. And so she had a giant periapical infection and no bone to the nose. There's really no bone to grab, and a big periapical fenestration over there too. So this is not an intact socket, but man, so the day of surgery comes, and I told her, I was like, we got to graft, come back and place the implant 4 months later, but we'll do it 4 months on the dot. She's like, okay. But she's crying the whole procedure. We even sedated her and she's still crying. She's still shedding some tears, and it's just not fun. I'm nervous and uncomfortable with the crying, and I just shoved bone in the socket and closed it up and did my figure 8 suture. And I was like, you know what? Hopefully she heals well. And then I sent her off. And then she comes back 4 months later and we take a new cone beam. And if you know cone beams, what you're seeing right now is pretty much the lack thereof of bone. You're seeing too much implant in your planned implant position. So this is me trying to plan an implant, and pretty much it just looks like it's granulated bone all the way to the implant. It looks like the socket is pretty much still there, minus even more bone. So it looks like we got less than we even started with after me just haphazardly grafting that socket. And so I'm like, oh man, I got to go back into the room here and tell this poor patient that despite our attempts to graft, we're going to have to probably graft or augment this ridge for another 6 months keep her in an Essex tray or a Merrill, whatever, temporize her for 6 more months, then maybe come back and place the implant. Maybe all of these, maybe. Man, and she's crying less. She's crying less this time. I actually had a chance to like have a normal conversation with this patient. And of course, my immediate response when I walk into the room, I say, heck yeah, let's do this implant tomorrow. So I see her the next day. And the only reason I can do this is because I have great technology. I know I can get this implant despite crap bone. I can get that implant where I need to get it. I'm looking and planning this implant position and seeing that, yes, despite missing a lot of bone on the facial of this implant, there is a lot of bone. There's more bone palatally and at the apex now. So I can potentially anchor this implant in, which I couldn't before. There was too much void or absence of bone. Now I can anchor it in, but a lot of my implant's going to be exposed. But I'm also looking at the edges of like the neighboring peaks of bone around the implant. It's almost contained where if I put this implant in and I'm indeed am seeing this much implant exposed, I can probably lock it in, and I can probably lock it in an ideal restorative position because right now it's positioned ideally for a cingulum axis hole. Then if I can get good grafting material around this and do it properly, I might be able to do this implant in one shot and not have to augment and then come back and place the implant. I can do it together at the same time. So I'm feeling confident. I got great, and we will do an episode on ridge augmentation and using membranes and barrier membranes to get crazy good results with bone grafting. But I know my guide will put me in the right place. But with this mixed density, I will tell you, I am concerned about the drill on how it feels when I'm trying to place this dental implant. But I have, the teeth are virgin teeth next door. This guide merging process was perfect. So I know my implant's going where it intended. So I merged my cone beam and my intraoral scan on point because these are all virgin teeth. If there's crowns everywhere, if there's metal, if there's fillings, all that's going to distort your merger. So if every tooth is touched in the mouth, get ready to barely trust that guide. It's hard. It's hard because it's going to create a lot of scatter in the cone beam. So when you're trying to merge it with an intraoral scan, your intraoral scan is going to be crisp, but the merger of the cone beam to that's going to be tough. And as you can see here, I'm planning my implant based off the cone beam, and I'm making my guide based off the teeth. The actual physical jig is based off the teeth. So the intraoral scan is really just to help you, plan the tooth position, not the implant position, the tooth position, and to help figure out where the guide's going to sit, like what teeth are going to sit on. Your cone beam is still dictating where your implant mostly, for the most part, is going, like where it's going in the bone. So the merger of the two are on point in this case. And also the fit is going to be great because these teeth, she's been in an Essex tray the whole time. If you don't have an Essex tray and you wait too long between your, like you take a cone beam, you take an intraoral scan, and let's say you wait 3-4 months before you actually go to implant surgery, your guide might not fit if they don't wear a retainer or an Essex. So sometimes I tell them the Essex tray is almost important to keep the teeth in the right position so that my guide will fit properly. And also your teeth won't shift too much. If you do these cases and do not temporize anything, there will be some shifting, which it can make it restoratively difficult later and also make it difficult for things to fit like guides if teeth are on the move. So there's some benefit to talking to patients about making these kind of Essex trays or retainers. So sometimes even in posterior cases, when I hear a patient being like, I'm worried about things drifting and it's going to, like, I got to travel. We're in Florida, so we lose people to snowbirds all the time to snowbirding. And so what I will tell them is, let's make you an Essex tray. I'll half off, again, still making a penny off it, but it'll help retain your teeth in the correct position. And sometimes it helps with the bite too. It's kind of evening the load of the bite by having that Essex tray. So again, her teeth are in the right position. This guide, even to depth, I'm using it because there's a slit, and this is the prime taper. This is a Dentsply prime taper implant. Great threading for great immediate lock. And on the X-ray, it looks great. Like my implant, looks perfect. Like why would you need to do anything else, right? If you don't flap, you don't see crap like this. Now, I didn't do any crazy flap design. I literally just went Crestal and into the sulcus of the neighboring teeth. I didn't drop any vertical incisions because, again, she was crying a lot less this time, but still very nervous and anxious patient. So I didn't want to open her up, drop vertical lines in the anterior anywhere. That would increase discomfort, possible aesthetic issues. So I wanted to try to keep, I didn't even lift the palatal. I barely touched the palatal tissue here. Because I'll tell you, if you start opening up a big palatal flap, that's when you start losing papilla even faster in these cases. If you lift a facial and a palatal flap on the two neighboring teeth, you'll lose more papilla versus keeping the palatal flap intact. Like maybe just tunneling right behind the implant and not touching the papilla areas. You can still tuck your membrane if you need one. Here you need one. Without touching those papillas. This is a great shot though, because you can see how much of my implant, that cone beam was right. I mean, none of that bone, it looks like the socket is still there. I preserved the socket. I didn't preserve the ridge. I preserved the damn socket. And there's so much nasty granulation tissue still kind of present. So I cleaned it up really well. I used a laser, not directly on the implant, but on the granulated tissue around it. But my implant's restoratively right where it freaking needs to be. I packed particulate bone on the facial of that defect so that I don't have to look at all this. I'm looking at probably 90% of that implant on the facial right now. But again, it locked in, great primary stability. There's other ways I could have handled this case for sure, but this is just one of many. I would have tried to temporize in another format. I would have used a slightly different tunneling procedure. But again, too much variation. I needed this implant to integrate, and I needed bone back, and I couldn't fail this time. So I had to open up, get a good visual, get good cleaning, get the implant in the right place my particulate bone, and placed allograft, cortical cancellous mix, layered my Ossix Plus membrane. This is a collagen cross-linked membrane. It's cross-linked, not a native collagen membrane. Native collagen membranes often disappear, in my opinion, a little too fast for the regenerative process to really peak. And I need it. I mean, I need bone here. I really can't miss out on any bone. So this cross-linked collagen membrane lasts longer to give better bone regeneration. I'll tell you, the bone regeneration I get out of this membrane is phenomenal. And so and it's resorbable, but I'll tell you, it lasts months on end, which I feel like a non-cross-linked membrane, like a native collagen membrane, like a BioGuide, BioHorizons, I think Memlock, those things dissolve pretty quick. They're just like native collagen. And we'll go through that information on another episode, but I was able to tuck in the membrane on the palatal, covered the defect on the facial. And again, no vertical releasings. You can see that the papillas are like no papillas other than the ones exactly at the site of number 8 was cut. This is a number 8 position. I don't know if I got to mention that earlier. But once I layer the membrane, I place platelet-rich fibrin. I use that a lot. We had that PRF episode. I place the platelet-rich fibrin on top, and I do not actually get primary closure on this case. I used a horizontal mattress suture deeper. So I always put this deeper horizontal mattress suture. I mean, I'm talking like 10 millimeters down from the edge of your flap. And basically this horizontal mattress suture will put a lot of tension. I use all the tension there, but it's not at the edge of the flap where the blood supply is the least. It's way deeper, almost in the mucosa where there's more blood vessels. So I can put tons of tension there and have a less risk of necrosis. So I put a lot of tension there. It also kind of pushes the membrane down deeper, almost tacks the membrane down in some scenarios. And then I did interrupted sutures on top. I did 3 interrupted sutures on top. So not that many sutures went into place on this patient. And I did not get primary closure. It's slightly open, which I'm honestly, in hindsight, like if she wasn't a nervous Nelly, I probably would have flapped. I would have dropped a vertical, or I might have even made a tunnel flap. So I wouldn't have disrupted the soft tissue and try to keep as much primary closure as possible. But, the regenerative material, the cross-linked collagen membrane, you can leave that one slightly exposed, that Ossix Plus membrane, and it does perfectly fine. It's cross-linked with ribose, which is sugar. Your mouth will take care of that if it's exposed, but the stuff that's still underneath the tissue hangs around. And honestly, in the upper anterior, I hate advancing the flap. I really don't like advancing a flap because you kind of destroy the mucosal line. Like you create an aesthetic issue by dragging the mucosa further up and trying to get primary closure in these upper anterior sites. So a little bit of opening like this just a little bit, kind of gives me some extra keratinized tissue. So fast forward 3 months later, she's like, all right, like, everything healed well and very minimal discomfort. It's time to expose. And this is the best part. Like, I open up and if I don't see my cover screw, I get so thrilled. Everyone's like, oh, you got to dig through bone. I'm telling you, if you see your cover screw in like one thread of your implant, that's not a good start to a dental implant. I want to dig through bone that grew on top. I mean, this bone is hard as a rock. Like, it's super solid as a rock bone that I have to drill through when I open up in 3 months, 3 to 4 months. Longer I wait, the harder, the more mature that bone gets. And I don't get a lot of granules. I feel like often when I was using native collagen membranes, I'd get granules in these areas that made it obvious that the membrane stopped protecting at some point and soft tissue started to dive in on my bone graft and mix it up a little bit, which always, from a long-term standpoint, makes you question how much bone you're actually going to get there in the long term. But I got something rock solid that bleeds out the gate. That's great. I'd dig through these solid bone regeneration cases to get to my cover screw any day. And again, the bone feels very vital. I'm not seeing a lot of particulate anymore. No defect on the facial. It's all covered with hard osseous structure. I roll my tissue. And again, a great thing about getting so digital is that I use digital components. Not even at this point, I would scan the implant, even at this stage at uncovery, because this patient needs a temp now. I can make one. I can make a chairside one, but I suck at making chairside temps. I'm a periodontist, and I don't like it. I don't freaking like it. I got a printer. I got an intraoral. I have the tools. And honestly, my lab technicians are awesome, but there's also AI tools like a company called DentBird where you could just make it in-house, design it in-house for relatively cheap, like $2. And then if you got a 3D printer and you can print it, and then you got like Onyx resin or other temporary materials, you can print it and paint it yourself. But I like to scan a lot of times for temps. And my lab, I have temp cylinders. I have tie bases that I use. So this one was actually this one, it was a tie base based temp, but then the lab actually, just by an error, actually ended up making the custom abutment that came soon after. And so then I ended up just putting a custom abutment and a temp on that and sending it to and had her actually rock that for most of the uncovery. Because at this point, the implant's integrated. So I'm just watching soft tissue heal. This is essentially 1 week after the procedures. You're looking at me putting in a temp on this patient so that she doesn't have to walk around too long without a tooth. And also, the sooner I can get in a temp, the sooner I can start developing soft tissue. And papilla will start to fill in these areas. So you can see the custom abutment with the actual temp on top of it. And due time, because I know my papillas will fill in over here depending on my contact point and where my peaks of bone are. So I have, according to Tarnow studies, if you got a good peak of bone and a temporary provisional in place, if you have a nice broad contact, the contact point to your peak of bone is going to determine if you get a papilla to fill in. And so if I got that like 3 to 5 millimeter range, depending on their thickness of tissue. So if they're a thicker biotype, you're more likely to fill in at wider ranges versus like if they're a thin biotype, you're going to want that contact point to the peak of bone to be a little bit closer to generate that papilla. But we were able to keep this patient on a normal timeline thanks to the guide and thanks to dope regenerative material. So that was the case of the crying scooter girl. I'm going to show another case. Okay, so this one's more from periodontal bone loss. So guy lost a lot of bone due to periodontal disease. I mean, tons of bone. I mean, to the point where like we do have to consider using, again, they can't take the teeth out and shove bone in. You're going to want to because the gums are swollen, so it doesn't look like it's that much bone loss. But when you take these teeth out and you really feel around inside the socket, this is an 8 and 9, again, an 8 and 9 with tons of periodontal bone loss. You take those teeth out, and again, easy to take them out. Your soft tissue is going to look a lot higher because you've got so much swollen gum tissue on these periodontally compromised cases. So the bone loss is actually much more significant than it looks. So if you don't do any kind of barrier membrane or some kind of extra fancy grafting technique, your bone regeneration is definitely going to be limited. Again, I'll come back to this case and like when we talk about regenerating bone in tougher sockets. But again, I didn't do anything fancy in this case. I didn't drop any verticals. I extended further horizontally, but I used a barrier membrane with cortical cancellous bone use what I call my horizontal mattress sutures again to kind of help tack the membrane down and take tension away from the edge of the flap. So that when I do interrupted sutures on the edge of the flap, again, I'm not necrosing the tissue. And I use my platelet-rich fibrin on top of my barrier membrane. And I did not get primary closure over 8 and 9. Again, I hate advancing the flap there. If I advance the flap on a socket graft in 8 and 9, I'm going to be fighting to get my soft tissue in a better place again. And this guy, had virgin teeth next door, except for the fact that he had calculus all over them all the time. But with that, I gain extra keratinized tissue when I don't get primary closure. And yes, my membrane will dissolve on the crestal portion. Will I lose a little bit of regenerative potential there? Absolutely. But I'll get enough because my barrier membrane on the facial and palatal will still stay put to the point where you can see here in this picture, if you're looking at the pictures, those nice capillaries showing that I'm getting new soft tissue to grow in over there. This case, I got so much bone to regenerate and so much soft tissue because I didn't get. So I got bone and soft tissue. Bone thanks to my regenerative technique with the membrane and the allograft and the platelet-rich fibrin, all being used together in a perfect storm. But I got so much soft tissue on this case. Again, this could have been like a really complex case to ever bounce back aesthetically, ever bounce back. So like it surgically could have been much more complex and painful for the patient. But again, advanced regenerative materials, great digital tools can make implant dentistry easier and more efficient. So much so that I got tons of bone and soft tissue that I could do this implant surgery without having to pick up a scalpel. I use this essentially with tissue punches through the guide. The guide actually, the surgical guide itself has a tissue punch drill. And I was actually able, in this case, to actually send out the scans that I did for myself. When I'm using the software to plan the guide, I can actually send that plan to a lab. Certain labs know how to handle this information, but you can send it to a lab technician. And I did on this case, this 8 and 9 case. I sent my pre-op plan, so my cone beam, my implant, and I plan my implants to almost exact depth that I want and exact positioning for a cingulum and everything like that. I sent that plan to a lab technician so that they could see my actual design plan for the guide, and they can see my guide too. They can then use that information to create abutments right away or temps right away before the actual surgery goes down. But a key thing to this is you have to use the guide fully guided. Again, native teeth makes it easier to merge. If they've all got all native teeth, merging your cone beam and your intraoral scan. So if you, again, want to pick your first case, pick some virgin teeth. Don't pick a teeth patient who's got crowns everywhere and your cone beam is going to have a lot of scatter. It's going to make it hard to merge the two. So nice crisp cone beam, nice crisp intraoral scan. I merge the two in the software. Great merger. Feeling confident about the bone density of where my implant's going to go. So again, the thing is on this case too, the 8 and 9 region, there's so much bone loss on the facial that a lot of the bone on the front end of this implant is grafted bone. So it's slightly different density than native bone. So as my drill goes through, it's going to hit native bone almost the same way as like an immediate implant, where like the socket is slightly tilted. And I'm on the shared screen right now, I'm showing the line of where the old socket wall used to be. And if you see this line right here, if you go free-handed, your drill might hit that and slide. Even with a guide, your drill might hit that bone and slide and derail you from putting it in the exactly correct position. So you have to be mindful of that. You have to feel the bone and try to, almost even in the guide, aim it more palatally, just a slight press more palatally. And also, even at the crest over here, you can see it's not like a flat surface. It rarely ever is. So if you were to take the drill and hit, you might also slide too palatally. And you take off your guide, you'll notice your hole is like way off to the palate, or maybe just even in soft tissue sometimes. So sometimes I'll actually plasty the bone just a little bit to make it flatter. So when my first drill hits the bone, it's catching that point and going exactly where it needs to go. The flatter the bone, the easier the guided drill will work. If it's sloped by any means, be ready to either modify or try to hold your drill in varying positions to prevent that slide from happening. I see this happen all the time where in cases like this, it will slide palatally because the bone is sloped palatally. It'll hit and you'll take the guide off and you'll feel like your access hole is so palatal. It probably did that. Now, what will happen if you do this case free-handed, people often put the implant right in the mid-crest. And again, they're not in the correct position anymore. So having the guide, I'll tell you, often when I take these guides off, my hole will look palatal, but I know because I looked at my plan, I'm like, that hole actually was meant to go palatal on the crest. It looks really palatal clinically, but that's just where the most ideal position for it. And you can look right here. I drew out, I planned out where I want my teeth to look, my CEJ. It's almost level with bone over here. So I always get the questions like, should your implant, like, where should you plan to place your implant? If you were to not have a guide here, you'd probably place this implant at the crest of bone and it would be way too shallow. If you place this implant and you just opened up a flap and try to place it right where you think it needs to go without taking a look at a cone beam like this and really planning out, because here I planned out about 3 to 4 millimeters of depth for soft tissue, which is what you need for your implants. But if I didn't do that and just flapped open and placed the implant at the crest of bone, my crest of bone is almost touching my planned tooth position. That means that I would have like no soft tissue between the anticipated gingival margin of my prosthetic tooth and my implant head. There'd be no distance there. There's no the body responds by crestal bone loss around the implant. It'll try to create that biologic width. But knowing this, I know I'm going to have to plasty about maybe 2 millimeters of bone before I actually get to the head of my implant. And I need to get there because I have the lab sending me prefabricated custom abutments. This patient was being sent to a restorative doctor that likes me to give them custom abutments that they can cement crowns on. I know it's not the best way to do it, but it's the way that I have to work with some of my referring doctors. So I wanted the custom abutments on at the same time because there is this concept of the less things you remove off the implant, like even a healing abutment, removing it off once or twice disrupts the soft tissue enough to actually harm the bone around the implant. So there's this concept of one-time one abutment where you put on an abutment, whether it's a custom abutment, stock abutment, healing cap, whatever it may be, you want to take it on and off as less as possible to disrupt the soft tissue as less as possible. So as least as possible. So I wanted custom abutments made already for this patient. So I placed my implants and then pretty much right away, I'm putting on custom abutments and putting on splinted provisionals out of occlusion. That's why they're a little bit shorter on that patient. And then again, you can see here the implants are like deeper on that crestal bone because that's where it needed to be to give good emergence for those custom abutments, which then I can send off and let them heal. And then in that process of healing, they're going to grow some papilla by having those temps in for about 3 to 4 months. And the splinted provisionals makes me feel a little bit better about any potential erratic forces. Now, granted, those temps have 0 bite right now in excursives or MICP, whatever, in any form of bite that those teeth are not touching. And that has to be that way if these implants are placed and provisionalized immediately. Those provisionals cannot touch. But again, that whole process of being able to have a digital workflow and having my 3D printer and everything took me to the ability to be able to make this super smooth implant transition for this patient. I mean, this was, go back to it, if you remember where they started initially with a severe defect in positioning, and I was able to take them with one easy grafting procedure and one super simple implant procedure, was able to take them to provisionalize them and give them, again, they're going to have to go 3-4 months. I never see the patient again. They went off to the restorative doctor. That restorative doctor I trust to be able to check the integration and see if they need to send back for me. So I saw this patient once for a consult, and we scanned for the guide. Once for the consult then we saw him for the extraction and bone grafting. Then took the pre-op visit. Then did the surgery and delivered those temps. I saw the patient like 4 times, and they're gone. They're off to the races on this beautiful potential result. And I never got to see this patient back. Not a patient I got to maintain for any other reason, which is good. Often if I don't ever see them back, and this case was done maybe 6 years ago. So they're doing pretty well. They got to be doing pretty well. Again, all possible with these surgical guides. It makes it so much easier to kind of be on point. And of course, expand your whole skill set as well. Again, we'll be back with other types of surgical guide cases. And again, if there's any other cases that you do want us to look at, or specific types of cases that maybe you ran into, I can also tag on cases where people maybe, in case you really want us to kind of hash over, I could present those cases if you're okay with them, the patient's okay. We can't present them on these podcasts, and essentially share what I would do with it with the rest of you, and talk about how different tools and technologies that you can use to kind of execute these cases. Again, thank you guys for listening and getting unfiltered with me. So again, we do this for the love of it, the passion of it. Go ahead and comment, like, share, and thank you guys again for getting unfiltered.